Hello, everyone. So I have now got this talk summary for you, which is titled as The Transgender Population Improving Awareness for Gynecologists and Their Role in the Provision of Care. So this is quite a favorite exam topic at the minute. And also this information is not really covered elsewhere in the guidelines. So it's important that you pay attention so you can learn the important salient points. Please give this video a thumbs up and share it with your colleagues and friends, and also subscribe to my channel if you haven't already. So the key content in this article is the UK's transgender and non-binary population is expanding, and this is reflected in the annual number of referrals to general identity clinics. Gender identity clinics offer a wide range of care to transgender patients, including hormone treatment and gender reassignment surgery. However, increased demand has led to long waiting times for these clinics. All transgender patients who wish to transition should be offered a fertility consultation to explore their options, which may involve fertility preservation, such as sperm or oocyte cryopreservation. Gynecologists form a part of the MDT team who engage with transgender and non-binary patients either as part of the transition stage, performing surgery, or managing pre or post transition gynecological problems. Gynecologists should be aware of the potential barriers to healthcare often faced by transgender patients and how the way in which patients are addressed during a consultation can improve their experience within the healthcare system. So why study this topic? So transgender population is increasing and people are transitioning at an earlier age. You should be able to provide non-judgmental, supportive, and proactive management. Gender dysphoria must be taken seriously, and referral to gender identity clinics should be done. There's about 12 gender identity clinics across England, Scotland, and Northern Ireland. All patients with gender dysphoria should be offered counselling and psychotherapy. So options of and eligibility criteria for gender treatments. There is a persistent and well-documented gender dysphoria. The patient has the capacity to make informed decisions and give consent. Any significant medical or mental health concerns present are reasonably controlled. The patient has a realistic, achievable plan that has either been implemented or is about to be implemented at an established and agreed time. So gender reassignment surgery for the trans men. So bilateral mastectomy and chest reconstruction, hysterectomy, vaginectomy, salpingo-oophorectomy, metoidoplasty, phalloplasty, urethroplasty, scrotoplasty, implantation of penis or testicular prosthesis. Gender reassignment surgery for trans women, penectomy or chydectomy, vaginoplasty, clitoroplasty, labiaplasty, cricothyroid approximation, thyroid cartilage reduction, breast augmentation, and feminizing facial surgery. So testosterone can be replaced either IM, so that's a 250 to 500 milligrams injection every 2 to 6 weeks. It can be replaced by testosterone gel, which is 5 milligrams daily, or testosterone again 1 gram every 10 to 14 weeks by IM injection. Estrogen therapy is available in tablets, transdermal gel, and patches. So fertility options are oocyte cryopreservation, ovarian tissue cryopreservation, sperm cryopreservation, and surgical sperm extraction. So it's important that pregnancy in trans men is referred to as they're referred to as pregnant people as opposed to expectant mothers. Transgender women have a HIV prevalence rate of 19%. Cervical screening. So trans men who have retained their cervix should have cervical screening. It's normally the responsibility of the GP to make sure these patients are in the cervical screening program and they're invited for routine cervical screening. So risk factors for cervical cancer, such as HPV, infection, smoking, are the same as they are for cis women. Fewer trans men take up cervical screening than cis women do. There was a national transgender discrimination survey done, which showed that 48% of trans men report postponing or avoiding smear test because of fear of discrimination. This tenfold increased rate of inadequate cytology from these smear tests because of the effects of testosterone on them. And in these cases, HPV testing should be adequate. So if it's HPV negative, that should be reassuring enough. Well, that's it. That's all the important points that I thought were important for the MRCOG exam. So please do give this video a thumbs up and do subscribe to my channel if you haven't already. And I hope I've tried to make this topic a little bit easier for you so you can revise well for your exams.